Well, good afternoon, everyone, and thank you for inviting me back. This is Brian Buchanan, practicing podiatrist and foot and ankle specialist in Grand Rapids, Michigan with the Spectrum Health Medical Group. I'm here today to discuss lateral ankle instability with you, which is a very common topic, something that we all see. I have no disclosures. So, of course, there are two types of ankle instability in the lateral ankle, acute and chronic. The acute injury is often treated conservatively on the front end, knowing that many of them will hopefully not become chronically unstable, and that this can be treated with aggressive rehab and appropriate first-line therapy. Rarely are we really repairing these acutely torn ligaments, except for really severe injuries, maybe high-demand athletes or physical individuals. So most of this really comes down to the chronically unstable lateral ankle, and that's what this talk is really about. We will go over these things when we go through this presentation, the anatomy or pertinent anatomy of the problem, a little bit on the exam of the ankle, of course a little bit of non-surgical treatments, but mostly talk about kind of the surgical approach to this problem. So when we talk about the lateral ankle ligament, we're really talking about the three main stabilizing ankle ligaments: the anterotalofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. The accessory distal syndesmotic ligament, the distal anterior inferior tib-fib ligament, does play a little bit of a role here and can be very challenging, especially in the high ankle sprain. We'll get into this at the end of the talk. And of course, the peroneal tendons. My next talk will be on that, so I'll save most of that for that. When we look at the anterotalofibular ligament, this is essentially a thickening of the capsule into one or two bands in the lateral side of the ankle, and it goes from the anterior distal fibula to the lateral talus. You can see here on the cadaveric ankle here, or talus, you can see marks 4 and 5. This is the attachment site of the anterotalofibular ligament, just past the cartilage that articulates with the lateral fibula, and just before the neck of the talus. This is the weakest of the three ankle ligaments, and it is involved in almost all of these ankle sprains. And so whenever you're seeing a patient with an unstable ankle or an injury, it's generally going to be this ligament plus or minus others, and it is the primary restraint of inversion, but especially with a plantar flexed foot. Next up is the calcaneofibular ligament, which is an extracapsular true ligament. It is outside of the ankle joint, and it goes from the tip of the fibula very close or adjacent to the anterior talofibular origin and attaches to the lateral side of the calcaneus. And it is the primary inversion restraint when the ankle is in dorsiflexion or neutral position, and of course it crosses both the ankle and the subtalar joint. So here you can see the CFL ligament going from the tip of the fibula to the side of the or lateral wall of the calcaneus, and the peroneal tendons running over top of this. So here you can see the positions of the foot and what ligaments are involved or most stable. On the left shows a plantigrade or neutral foot position where the CFL is almost parallel to the weight-bearing surface, and on the right, which is the more traditional ankle sprain position, you see the anterotalofibular kind of assuming this more neutral or parallel position to the weight-bearing force. When these ligaments are in this position is when they're able to resist inversion more effectively. This is a cadaveric dissection from Serafian's book that showed the influence of the rear foot on the calcaneofibular ligament. So the photo above, or labeled A, shows the calcaneofibular ligament in a very valgus or flat foot position. This is almost approaching a horizontal position. Figure B is in a cavus or varus type heel, and you can see how close to parallel to the weight-bearing surface this is. So this is where the rear foot position and the whole foot architecture really can affect the lateral ankle, and we do need to address this. Ankle injuries or ankle sprains are extremely common, happen to approximately 1 to 10,000 people per day in the United States. Of course, in athletics and sports, it's much higher. It is the most frequent ankle injury that we will see, or athletic injury, that we will see in our office or in the clinic. The big take-home message here, though, is that over half of these patients will have some residual symptoms. They could be very mild: stiffness, irritation, swelling, nerve injury, and some can be much more significant. And the significant ones are the ones we're going to really need to treat. These are patients that have ongoing pain that doesn't go away, or continued spraining of the ankle where they never did before. These are the patients that present into our office. When we see these patients, we do have to subdivide two types of instability. Is this mechanical instability, where there's true ligamentous laxity, or ligamentous laxity in the sense where it's not stable? You're able to stress these patients and you feel it's a loose ankle joint. And so these are the type of patients that are amenable to an operation. Functional instability is a bit different. This is a little bit more vague, where patients will subjectively complain that their ankle feels weak or feels like it's going to give out, though physically they have a stable ankle. I do see this in patients who have osteochondral lesions but no ankle instability, which is not that common, but it does happen sometimes where their ankle ligaments are fine and they don't have mechanical instability, but they'll often complain that their ankle is giving out when in fact there may be other pathology happening. So sometimes this happens in cases where people do not have the ability to do balance. They have impaired proprioception from stroke or neurovascular issues, some types of strength loss, weakened perineals, or in the or elderly patient or somebody with a disease such as Parkinson's, where they just don't have good postural control and their ankle feels weak. These are not the patients you necessarily want to do an operation on, since it may not benefit them as much, and other things such as bracing and therapy may be more beneficial. So when we look at the physical exam on this patient, most people do complain of a remote history of injury. Sometimes it's many, many years ago. The patient will often come in and say, yes, doc, I wrecked my ankle in high school, and it's been pretty good up until the last 5 years or so, and now it's been getting worse, whether it's from a more recent injury or a type of job they do, or maybe some weight that they've gained over the years. It can start to unmask some of these problems. They often will say that their ankle just doesn't feel stable. They don't trust it. They don't want to go do anything anymore, especially on certain surfaces where this tends to cause problems. This can be associated, of course, with more generalized conditions such as generalized ligamentous laxity and Ehlers-Danlos syndrome or some version like that. Rear foot varus or a varus type heel, of course, can increase the strain on the lateral ankle, increasing the risk of having problems or having an unstable joint, and of course a high arch or pes cavus foot structure. This will cause the patient to stop what they're doing or to do different things and to try to avoid some of these activities that they really do enjoy. We also have to look at other pathology that could be present. Of course, the distal syndesmosis we'll talk about at the end of this talk. Medial ankle ligament issues. If you have a patient with both medial and lateral ankle instability, those are particularly challenging. Osteochondral lesions, which we won't get into in detail, of course, can cause lots of ongoing problems with these unstable ankle joints. Of course, perineal tendon pathology, again, we'll talk about that at the next lecture. And then anything happening at the fifth metatarsal base that can be symptomatic, whether it's in a subacute fracture, arthritis, calcific tendonitis. So when we examine these patients, we always do an exam like the anterior drawer that you can see above, where you hold the front of the tibia, grasp the heel, and he's pointing right over where the ATFL would be located, and you can actually see the skin pucker as that talus slides anterior to the tibia, and that's demonstrating an incongruent or a deficient anterotalofibular ligament. This is a patient of mine done in the OR under anesthesia, where we're doing both tests, the anterior drawer and talar tilt. We're able to see that his ankle is a bit loose. More importantly, with this ankle, though, I could feel it clunking around his talus in the mortise, which really signifies instability as well. So these patients come in, of course, we get traditional ankle x-rays to rule out occult fractures or any kind of other pathology, bony pathology in the ankle joint. Question of doing a stress exam. Many people say you should do it. I don't typically do it routinely because after time you can kind of tell if it's unstable by feel. However, if you're not sure, this is a very good adjunct to really visually see is there true mechanical instability of the ankle joint. And then often we will get an MRI to look for other types of problems. So when we get an MRI, we are basically looking at the lateral ankle here, and you can see a very thin line of the anterotalofibular fibular ligament that goes from the distal fibula to the lateral talus. This should be a thin black line or a black line like this, where there's no white or fluid within this, there's no scarring, and everything looks very normal. This is an arthrogram, but really kind of highlights what we're talking about. When the ATFL is ruptured, you will often see this replaced by fluid. Even people that are chronically unstable and didn't have a new injury will have this kind of presentation in some of these MRIs, where they'll just have no ligament there, and that often backs up and goes with their complaints. But what we typically see with this in the chronic patient is this kind of scenario where you have an ATFL that looks like it's intact, but it's quite thickened, indicating that this has been injured and scarred. What we cannot tell on the MRI is this stable or not? And this was shown in this study done in Foot and Ankle International in 2017, where they looked at two groups of patients. They had 187 patients that had instability of the lateral ankle. They had an MRI, they had a stress exam, and they were scheduled for ankle ligament repair. And then they compared them to a control group where they had no ankle instability on stress exam, but they had an MRI. And then the radiologist, they were blinded blinded to which group was which, and they were given the MRIs and asked to say which ankles are unstable, and they couldn't do it. They could tell the pathology, but they could not tell with any specificity whether the ankles were unstable or not. So the MRI does not show instability. That's an incredibly important point, that you have to use your physical exam and history to kind of help figure out, are these ankles unstable? MRI does show lots of it and is very helpful and a good adjunct for this to look for other pathologies you may need to address, but it does not tell you that this ankle is unstable. So when we want to treat these, we always start with conservative treatment. Immobilization is, of course, extremely important in the acute injury. In the chronic injury, I have not found this to be highly successful, and that's been shown in the literature that it just really doesn't work if they're chronically unstable, but it is certainly worth trying in the acute. Of course, you would always do this with the acute sprain. Ankle bracing and therapy is the mainstay of treatment for chronic ankle instability. Therapy, I do think, can be very helpful in some patients, especially those that are not extremely unstable and just need a little help with their mechanics and with the functional instability that can occur with this. Sometimes patients have to modify activities, and that can keep them comfortable. If they used to play a lot of racquetball or tennis or lateral movement sports, but that always kind of brought up this problem, and they're willing to give it up, or they're ready to do so, that may be all they need to do to kind of solve this. However, there are many patients who don't want to give this up and are looking for solutions. And of course, we want to plan to prevent this in the future. If we can get them better, what can they do to not have this happen again? Sometimes that's easy to do, other times it's extremely difficult, and that leads us on to the next set of treatments, which is surgery. Now, surgical treatment for lateral ankle instability is subdivided into two groups. There's the anatomic and non-anatomic repair. The non-anatomic repair is a much bigger operation, often reserved for revisions, extremely overweight individuals, or very, very ligamentous lax individuals, where we need to use some type of non-anatomic meaning a fabricated ligament, whether it's an allograft or autograft, with bone tunnels and different types of fixation to try to really reconstruct these ankle ligaments. These ligaments or these surgeries can be challenging and often with relatively large incisions, so they're not the primary way that people will repair these. Anatomic repair is what almost everyone else will do, and this would be considered either a modified rostrum or an augmented rostrum. Now, with the lateral ankle stabilization procedure, do we need to do arthroscopy? If you're going to do the procedure open. I always do arthroscopy with these procedures now because of many studies that have shown that there's lots of intra-articular pathology in these ankle joints. And certainly I see that. Just about every single ankle that I will scope before doing a stabilization will have some type of issue going on. This is not 100%, but it's probably 85 to 90%, just like it's shown here. There will be most of the time we'll see significant synovitis or thickening of the capsule, and it makes sense that this could contribute to some impingement issues. And so cleaning that up is a very low-risk option and very, very easy to do with limited complications to really try to help these patients out. Now, occasionally you'll see some other things that the MRI missed, like loose body or loose fragments of bone, certainly fibrous bands or meniscoid bodies in the ankle. Rarely will we see an osteochondral lesion that the MRI missed, but certainly we can inspect the joint and fix whatever we can at the time. So arthroscopy is a good adjunct when you're doing these lateral ankle ligament surgeries. So when we think of repairing the ligament, what are the principles of ligament reconstruction? Well, number one is we do not want to over-tighten the ligament. This is incredibly important. If you do that, you can lead to patient dissatisfaction and pain, especially of the subtalar joint. When we use these augmented procedures, this increases the risk a bit. Early mobilization, if you can do it, is very helpful. This is a procedure that I've changed my recovery, which I found very important for patients, decreasing how long they have to stay off their ankle and off their foot in order for them to have a successful outcome. And we don't want to sacrifice any of the supporting structures if we can avoid it. So if we cannot take the peroneal tendon to do a transfer or split it to do a transfer, it's better, as these structures are clearly important for ankle stability. So I think we all know that the Brostrom procedure works. This has been shown in many, many studies over the years. This is a good procedure, and it has a very good track record. A recent review in the Journal of Foot and Ankle Surgery a few years ago looked at the midterm and long-term longevity and found that the revision rate was quite low at 8.5 years. So the question is, why would we want to do anything else? This seems to work well. Well, there's been some more recent studies that seems to have shown that this may not be actually true, especially in patients that are high demand. And our patients are becoming higher demand, it seems, where they're wanting to stay active much longer and much later in the life. They, of course, are more overweight than ever, and this is posing some technical difficulties in trying to keep some of these patients stable. So when we look at the Brostrom, where does the failure happen? Is it the suture you use? Is it the suture anchors you use? Well, this study done in the American Journal of Sports Medicine showed that it was neither. The failure happens within the tissue. It's the actual biology of the patient that fails in some of these ankles as opposed to the fixation, meaning that the bone anchors we place in the fibula almost never pull out. It's going to be that this tissue stretches back out if there's to be another injury that can lead to failure. So the problem is really the tissue. And that's where it leads to augmentation. So if the tissue is the issue, what do? Well, augment the repair seems to be the best option. This is where we would do a primary repair utilizing the Brostrom technique and then augmenting with something over top of it so that it would heal in an appropriate fashion. There are two options, at least two popular options in the market right now. Polyester implants, which I will use a corporate name for this, would be Arthrex's internal brace as an example. Smith & Nephew has a similar product. And then Artelon, which is a knitted polyurethane urea copolymer, which is quite the mouthful, but essentially this is a type 1 collagen synthetic ligament that is used in the ankle and knee and other parts of the body. But this is nice because it is a little bit stretchy, and it stretches about the same amount that the ATFL stretches, which is approximately 5 millimeters. So this more mimics natural tissue. This also becomes incorporated into the body like a graft would in about 4, 5, 6 years from implantation. So it's not a synthetic the same way that the polyester implants or internal brace implants are. That fiber tape doesn't go anywhere, and that stays around for life. So there are some benefits to this. The question is it strong enough? So when we look at these devices we use to augment these repairs, how strong are they? This study, again done in the American Journal of Sports Medicine, was a cadaveric study where they loaded these lateral ankles and found that on average it took 160 newtons to cause the ATFL to rupture. They did the same thing with the flex band or Artelon and found it was very similar at 172 newtons, so this mimics the natural tissue. And internal brace was quite a bit stronger at 250 newtons, so this is a very robust repair and extremely helpful in those really lax or overweight individuals that need to be stabilized. So when we think of the augmented repair, what are we actually doing? This is not an artificial ligament. We are not using these devices to reconstruct the ligament by themselves. The whole idea here is that we are doing our traditional Brostrom repair. We are stabilizing the lateral ankle ligament complex and using these devices to augment that repair, with the basic idea that if a patient is 8 to 10 weeks from surgery and is back in a regular shoe and twists their ankle on the sidewalk, that maybe they won't stretch this thing out. That is one of those times where early injury following surgery can lead to long-term failure. If we can have some type of device in there to keep them more stable, it can protect the Brostrom repair so that it will heal on its own as it should. So this acts as a check rein, as they call it, to keep everything stable and allowing that primary repair to heal safely. This is also used in ACL reconstructive surgery in the knee to basically protect the ligament or whatever ligament graft they are using, synthetic or autograft, to repair that ligament. So it's been extremely successful in other parts of the body as well. So this is not an artificial ligament, but you do have to be careful not to over tighten the joint. You can get a little carried away thinking that tighter is better in these joints that are loose, and you can make them quite a bit tighter than they probably should be, especially the subtalar joint. If you are fixing both the ATFL and the CFL ligament, you need to be very cautious that you're not over tightening that subtalar joint. That often leads to ongoing problems and patient dissatisfaction. So when we think of why these surgeries will fail, we know that the tissue is the failure spot, not the anchors or not the suture. We need to make sure we always address the foot mechanics that lead to overload of the lateral aspect of the ankle. Certainly this is the realm of the varus heel or pes cavus foot structure, whether you need to do a lateral calcaneal osteotomy or you need to do a dorsiflexury osteotomy, the first metatarsal base. It's incredibly important to balance this foot out to try to get this into a good stable position. This is critical, especially in the revision patient, but something to always consider when you're thinking not just of the lateral ankle, but also how the foot influences this joint. The presence or absence of arthritis in the ankle can clearly lead to worse outcomes. There's more pain in these patients. These can be very, very challenging patients to try to help who have, maybe they're young and they had a previous injury and their ankle's in varus and it's arthritic, and can you make them better with stabilizing the ankle? And the answer is not always. Certainly it's probably worth trying. As you know, these patients are heading towards either some type of disability scenario or an ankle fusion or replacement at some point, though sometimes you like them to be a bit older before you consider that type of joint destructive operation. Stabilizing them, I think, is still worth doing. It does at least stage them, so if they were to have a replaced ankle joint, the ligaments would be in a good position, or at least hopefully be in a good position to make your ankle replacement a safer operation. And of course, obesity is a major risk factor for why these things fail, which is where the augmenting the rostrum really comes into play. So what kind of complications do we see with the rostrum procedure? Well, it is a good procedure. It does not have a lot of complications. I typically don't get a whole lot of problems, so we will see some things pop up. Delayed wound healing happens, certainly, as it can in any procedure. I do see quite a bit of nerve injury numbness. A lot of this is transient, so it didn't quite make it into these numbers. These are more longer-term complications, but we will see some lateral branch of the superficial perineal nerve injury based on kind of the anatomy of the patient or where you put the incision, so being very careful to watch out for that is key, though sometimes it's almost impossible to completely miss. It will get entrapped, and so I tell every patient they absolutely will have numbness without question, and that hopefully in time it will get better, and there are some treatments if it doesn't. And then, of course, stiffness. We will make this ankle stiffer. We will make the subtalar joint stiffer. This is kind of the desired effect in telling patients that they will feel the stiffness, but that in time with therapy and as they kind of get on their ankle, this will loosen a little bit. We just have to make sure we don't over-tighten them. So this paper was a review that looked at rostrum traditional and rostrum with augmentation and found that the overall complication rate long-term was about just under 6%. So here's a patient of mine. This is a traditional ankle arthroscopy I'll do with a lateral ankle stabilization procedure. You can see all the synovitis that's kind of formed as a consequence of this injury, and we're putting traditional medial-lateral portals, just a simple blunt shaver in the lateral gutter, lateral portal, and just kind of cleaning all that stuff out. And I think if nothing else, helps decrease maybe some of this risk of impingement symptoms in the future. Also looking for any kinds of significant chondral issues or loose bodies, which this patient did not have. But I do think cleaning up the ankle joint arthroscopically does make some sense. It's very low risk, quite simple to do. And patients, I do think, have a little bit better pain relief immediately after surgery by cleaning out all this kind of synovitis that generally causes them discomfort. The other thing is when we're doing open lateral ankle repair, we could do this probably technically without the scope if we're just cleaning out the lateral gutter, but we also need to make sure we clean out the medial gutter. And as you can see here coming up in a second, there's often some junk that forms in that medial side, and it is important to do that through the scope as opposed to opening it up if you don't have to. So here we're getting down into that medial side of the ankle. No real joint pathology per se, but there's certainly a lot of kind of buildup of tissue that probably helps to clean up. As it's, again, a very simple thing. So when we think of the technical procedure, this is usually how I approach the simple rostrum procedure with augmentation, where we make a curvilinear incision. You can see here this is probably an extent of the lateral portal. This is not one of my patients, but that's kind of very similar to the incisions I will often make. This is probably a lateral branch of the superficial perineal nerve. You can see how close that is to the superior extent of this incision, so you have to watch out for that. Some people will do a linear incision down the middle of the fibula, especially if you're working on the perineals. I think that's a pretty good incision. Sometimes I will do two incisions, but I'm kind of getting away from that, and I think the linear incision makes a little bit more sense in most of these cases, but it kind of depends on what you're doing. This is a schematic of kind of how the repair is done or how I do the repair. You can see the ligament that's off the fibula. This is kind of the primary repair site. We have anchors into the fibula. You do not need to use anchors, but I often found them kind of helpful. At least it makes me feel better. This is going to be a strong repair. And we're able to then put in our augmentated anchor into the lateral side of the talus. This goes just anterior to the cartilage and kind of goes up, so it goes from inferior superior, so we're kind of going up into the talar body. This is very hard bone. One technique tip if you do this procedure is to, if it's hard bone, tap it twice. I've had a couple of these anchors shear off on insertion or not allow it to get down far enough because the bone was too hard and I just failed to do that. So tapping it twice really helps in these hard bones. It tends to happen in bigger guys, or sometimes in teenagers. They'll have very hard talus bone, and doing that certainly will not alter the strength of this anchor. So when you do that, then you're able to see the two anchors coming off the distal fibula, and then this is the fiber tape coming off the anchor in the lateral side of the talus. Then we go ahead and do our primary rostrum repair, which is shown here, where you have the two sutures and you have that ligament going from the talus back to the fibula. You have the anchor and the fiber tape coming out of the lateral talus, and then it's time to transfer that into the fibula for the augmentation. So here you can see the fiber tape coming off the lateral talus after the primary repair has been completed. Now we're able to take the fiber tape from the talar anchor into a push lock anchor and then into the fibula, and this is where you need to be careful that you don't over tighten it. You want to hold the ankle with slight plantar flexion. If you do it completely dorsiflexed up, then I think it creates a little bit more tightness when the ankle is in plantar flexion. Remember, that's the kind of position of tightness we want, which is with the ankle plantar flex, because we're dealing with an ATFL primary repair in this case. Here's the same patient that we had earlier, just flipped around, where now we're stressing his ankle after the repair has been completed, and it's extremely strong, and certainly I could feel that when I did that after the operation. So my postoperative care has changed. Without the augmentation, I was keeping people non-weight bearing 4 to 6 weeks. Now, when I'm just doing a rostrum with augmentation, I'm allowing them to walk after 2 weeks, so they're non-weight bearing in a splint for 2 weeks, then progressive to a weight bearing boot. At that point, if the sutures are out and incision looks good, they're in that boot for 4 weeks. So between weeks 2 and 6, they are doing a home exercise program the entire time, starting at 2 weeks out, assuming no incisional problems, doing lots of range of motion and eventual slow strength building, even though they're not standing on the foot. At that 6-week mark, we'll get them into an ankle brace and often into an athletic shoe with gradual advancement of activity, and then we'll start formal therapy. Sometimes I do have issues getting people to go to therapy given cost and time. However, I do think it's important to teach some good mechanics of how to really strengthen the ankle. They don't usually need a ton of therapy for these, but it can be very helpful to get them back to their sport or activity sooner. I always restrict running and jumping for 10 to 12 weeks from this operation. Even though it's a very good procedure and it's very strong, certainly a significant injury in the first 3 months of this type of surgery could be a big problem for these patients. And then after 12 weeks, they're able to really increase their activity. And then I usually have them wear an ankle brace or support 6 months from surgery, especially when they're doing their sport or especially when they're doing anything real physical. And it's just a safety net to be sure that they keep this robust repair intact so that they don't have trouble. So what are the outcomes? Well, the outcomes are good for this, and it definitely shows that the rostrum with augmentation is a bit better as far as returning to play and returning to sport. This is a recent study last year in the Foot and Ankle International that looked at 59 patients who had a primary and a regular rostrum gold procedure, and then 60 who had the same with the augmentation. In this case, it was internal brace. Both the patients and their therapists were blinded as to what procedure they had, and what they found is that the augmented rostrums returned to pre-injury level at 4.2 weeks faster. And so this allowed them to return to their sport, return to the activity sooner than just the rostrum alone. And this does make sense. If you augment it, you're going to have a patient that can resume their activity sooner than if you do not. So real quick, we'll talk quickly on distal syndesmotic issues, or what we call the anterior inferior tib-fib ligament instability. This is not super common, but often associated with a fibular fracture like a Weber C high fibular fracture or traditional syndesmotic disruption. However, I have had several patients that have had this type of problem without fracture, and it's easy to miss. Typically, they'll have pain more anterior, more superior, just above the lateral ankle ligament. However, it can be challenging to really identify this ligament, but you will see this on the MRI, so watch out for this, as it is a little bit of a separate clinical entity that does have an option. So what happens when the anterior inferior tib-fib ligament is compromised is that now the fibula can externally rotate without any restriction, and it can be quite significant. This is very hard to see on x-ray because we just can't see external rotation very well. CT scans sometimes will show this, but it is one of those things where you have to have a clinical suspicion based on the location of pain, type of injury, and how long this has been going on. So when we look at the anatomy, the anterior inferior tib-fib ligament basically is here. There's generally 2 fascicles. This is the main one that goes from the distal anterior lateral talus into the fibula. And the distal fascicle is what we call Bassett's lesion, where you'll see this in arthroscopic procedures, and you'll get an impingement in some of these if it's too thick that you want to clean up in this lateral side. But this is the main ligament that if it's ruptured or if it's broken, and there's a fracture obviously associated from this, the talus fracture on the distal lateral talus or tibia, that can lead to a functional or effective instability of this ligament not being intact. So the exam for this is a traditional external rotation exam, where you take the patient's foot, you essentially put it into a neutral position, and then you're trying to push that talus lateral or externally rotate the foot on the tibia. And patients, if they have this type of injury and you do this, they will absolutely hate you. It will be extremely uncomfortable for them. So you don't need to push very hard, but it is a good way to help determine if there is any compromise of that distal syndesmotic issue. This also, of course, will apply to any syndesmosis injury, but what we're really looking at is just the distal extent of this ligament. So when we look at the MRI, what we're looking at here, the MRI on the left shows a little bit of fluid here, kind of no big deal, not real specific. But this is the ATFL just before we get into the ankle joint. You can see a little bit of graying here during that thickened ligament. This is a chronically injured one. I don't know if this patient needed surgery or not, but this is the kind of stuff that we will sometimes pick up and say, yeah, if they still have continued pain and ongoing problems, would an operation help them? And sometimes the answer is yes. So it's just something to put into your bag of tricks, something to keep in mind, that sometimes these patients do need to be addressed surgically if they do not improve from a conservative standpoint. So when we talk about surgery real quick, we can still use the augmentated repair like we used in the Brostrom. We were able to use 2 anchors, one in the distal lateral, and the big one will go into the distal lateral tibia, and then you can anchor that into the fibula. This is shown with a tightrope fixation or endo button fixation from a traditional syndesmotic injury. However, you can do this, and I have done this several times, with no tightrope, where you just have the distal extent that's injured. And this will provide some external rotation force or stability to that fibula from these type of injuries that can be very challenging to identify. So in conclusion, lateral ankle instability is a very common clinical presentation, something that we all see and have to be aware of how to treat. Make sure you're always watching for other types of pathology that can really mess up your results if you don't know they're present. Do not trust the MRI only, especially for measuring instability. This has to be relied on both MRI and clinical and historical exam. The augmentated Brostrom is probably becoming a bit more of gold standard now. There are some people who still save it for revisions, and certainly that is fine. I've kind of moved to using it almost all the time because I see patients do so much better with quicker recoveries, and I just have a hard time not doing that for everybody who needs this type of repair. All arthroscopic Brostrom, something I don't have experience doing, but maybe trending towards. It's becoming more popular. Maybe looking at considering changing a little bit of the approach, and you can do it with the augmentated devices as well. And of course, don't forget about the anterior inferior tib fib ligament as a cause of persistent higher ankle pain. Thank you very much.